Thank you so much for coming tonight, everyone. We really appreciate you taking time out of this busy holiday season to join us and for coming to this rescheduled talk, The Fertility Journey, Understanding Treatment, Preservation, and Genetics. Tonight, I'm so excited. We have hosting Dr. Michelle Goldsammler and Risa Abittan, our certified genetic counselor at RMA of New York, Long Island. Dr. Michelle Goldsammler has been at RMA of New York, Long Island since
2023. So I've been here about
2023.
just about
Um,
3 years.
yes, perfect. And she has clinical expertise in both reproductive endocrinology and all aspects of fertility treatment, such as IUI, IVF, as well as preventative and medically indicated fertility preservation. And Dr. Goldsammler sees patients at both the Melville and Lake Success locations of RMA of New York, Long Island. As I said, Risa is our wonderful board-certified certified genetic counselor, and she provides guidance to our patients on reproductive genetics-related concerns, such as cytogenetic anomalies, carrier screening, family history concerns, and pre-implantation genetic testing of embryos. And Risa is also a very important resource for the staff at RMA of New York, Long Island. So welcome again to everyone who's joined us. If you have any questions, I would encourage you to put them into the Q&A at the bottom of the screen. And then Dr. Goldsammler and Risa will address those at the end of their presentation. But Dr. Goldsammler and Risa, thank you again for hosting this evening. By all means, feel free to start your presentation. Thank you.
Thank you so much. We're so happy to be here. I'm Michelle Goldsammler. I'm the REI here, one of the REIs here on staff at RMA Long Island. It is my honor to be here with Risa, our in-house genetic counselor. I'm so excited that we were able to do this together. I'm going to talk a little bit about fertility, a little bit about some of the background of fertility, a little bit about the evaluation and treatment, and definitely want to talk to you guys about the connection with genetics, specifically about who might want to, get some testing. When do we do that kind of testing? Things like that, because it's really a partnership with our genetics team here at RMA. And so first and foremost, just to kind of let you guys know what an REI really is. And so I have a couple of different hats that I wear, but we do full spectrum fertility care here at RMA, including regular fertility, primary infertility, secondary infertility. We do third-party reproduction with like donor egg, donor sperm, gestational carriers if we need. I do fertility preservation, freezing eggs, freezing embryos, freezing sperm. We're going to talk about that a little bit more today as well. I have other hats that I wear that we're not going to really focus on today, but I definitely also treat endocrine disorders. I'm a reproductive endocrinologist and infertility doc. And so I definitely treat hormonal things related to fertility like PCOS, primary ovarian insufficiency, and also recurrent pregnancy loss. But today we're really going to focus on that infertility piece of my role here as an REI. So infertility, there are a couple of different ways that we define it, but in general, infertility is 12 months of trying to conceive when you have a regular menstrual cycle and have adequate sperm exposure for women under the age of 35. When you do hit that age 35, the diagnosis kind of shortens to a 6-month period of trying to conceive. And at that point in time, you should definitely see a provider to kind of get an evaluation, see what's going on, and talk about a variety of different treatment techniques that we have available to us. And so, what are some of the reasons why people have trouble getting pregnant? Now, this is not an all-inclusive list. This is really just giving you a couple of broad categories that I want to go over. And obviously, at your consultation, we go into this in a lot more depth, kind of evaluate all these pieces in a lot more detail. But some of the reasons why people have some difficulty getting pregnant is an egg issue, an egg quantity issue, a number of egg issue, an egg quality issue. It could be an issue with growing those eggs in a coordinated way, that maybe there's some discoordination of signals between the brain and the ovary telling it to grow an egg, which we like to call hormonal issues. There are some anatomic things that can cause difficulty conceiving, either problems with the fallopian tubes or with the uterus or the cervix. There may be just some timing issues that we're not timing ovulation correctly, not timing sperm exposure correctly. And then there are some male factor issues as well. And when I evaluate a couple, if I have both a male and female partner, I do a full evaluation of everyone because 30% of the time I find more than one issue that we do need to address to kind of help that couple proceed. And so going into that in a little bit more detail in terms of egg quantity and quality, the actual strongest predictor of your egg number and egg quality is actually your age. And so we know for us as women, as we get older, the egg number goes down and egg quality goes down. There are a subset of women who have a lower number of eggs that's lower than we expect for their age. But there are certain things that put you at risk for that. There's some women that are just born with a smaller group of eggs than we previously thought. There are certain medical conditions that actually decrease or diminish that pool, that ovarian potential pool faster than we would have expected based on their age. So some things like autoimmune disease in certain circumstances can cause a diminish of that supply. There are certain genetic things that predispose you to have a lower egg count. We're going to focus on that a little bit later as well. And there are some things that we do in the medical field that we know is harmful to eggs that can diminish egg number. And so there are certain treatments, there are certain medical issues, certain surgeries we know that can impact your egg number. And so how, just to kind of review a little bit about quantity of eggs and how are we losing those eggs a little bit. So there is a natural decline as we get older. We actually had the most number of eggs when we were pregnant inside our mothers at 20 weeks of pregnancy. And by the time we're born, that number has already gone down to about 1 to 2 million. By the time we hit puberty, we're up to a couple 100,000. And then every month that we cycle, we're losing a group of eggs each month. Only one egg naturally grows and ovulates, but we're actually losing a group of microscopic eggs along that way. So that by the time we hit age 37, we have about 25,000. And then it starts to go down a little bit faster. 37 is one of those tipping points for us. And then 40 is also a tipping point for us. At 40, the rates go down a little bit faster as well. Now, you'll continue to have eggs until you hit menopause. At the age of menopause, you have about 1,000 eggs left, approximately, that then rapidly deplete over the next month or two. The average age of menopause in this country is 51, but that's just strictly terms of egg number. That doesn't mean that you can get pregnant at 51 with your own eggs, because it's not egg number by itself that makes a difference. It's egg quality that really matters. And egg quality, we know, also decreases with a woman's age. And so if you look here on this chart, just as a visual representation here, the red line is live birth rate. So as women get older, the chance of having a baby goes down over time. And kind of the rationale and reason for that is that the miscarriage rate goes up, which is consistent with the rate of abnormalities in eggs. That's what this blue line represents, aneuploidy or abnormality in eggs. And so we know that as women get older, there's higher rates of aneuploidy in eggs. And those eggs either just don't get you pregnant, which is why it's harder to get pregnant, or have more of a chance of having something that's genetically abnormal, creating abnormal pregnancies that have a higher rate of miscarriage. And we're going to go into a lot more detail about what we can do and what Risa can help us do in our office in terms of identifying those abnormal embryos and what we can do for that. And so, as you can see, at age 44, yes, you may be having eggs still, you're not in menopause yet. The chance of getting pregnant with your natural eggs is low without some help. And that's kind of related to egg quality. And so that's egg number and egg quality. We're going to talk briefly about some of the other causes of infertility, the signaling issues, some anatomic issues. And so signaling issues, I like to think of coordination between the brain, the ovaries, and the uterus. And so sometimes there's a miscommunication of the signal between the brain that tells the ovary to grow an egg. So that's some hormonal issues. There could be an ovary issue that the ovary doesn't have enough eggs to grow an egg in a nice, predictable way. It could be that you're ovulating earlier than you think, that there's a timing issue and you're not timing intercourse correctly, you're not timing sperm exposure correctly. So there are a lot of different things that can cause issues. Even though the brain seems normal, the ovaries seem normal, the uterus seems normal, it's that coordination between the two of them or the three of them that sometimes is altered and sometimes needs some assistance. There's also anatomic issues that can affect fertility, blocked fallopian tubes. The tubes are where egg and sperm actually combine, so you need to have at least one open tube to get pregnant. There's some anatomic issues that can happen in the uterus. For example, you can have an outgrowth of the lining tissue with something called a polyp. You can have an abnormality in the outgrowth of the muscle wall of the uterus. That's like a fibroid. Some people have some scar tissue in their uterus or were born with a different shape to their uterus that can affect their fertility. And so there are some anatomic things that can affect your fertility as well. And then the last category, big category, is the male factor. And so we definitely look at certain things that can cause issues with sperm production, with sperm quality, with sperm movement. So that's definitely part of our evaluation. And so now that we know some of those kind of causes of infertility, what happens when you come to our office and we do that evaluation? So the first step is we have a conversation. Our initial visit in the office is quite lengthy. We do a full history for all the reproductive partners. So female partner and their reproductive partner. We'll do a full history kind of assessing what are their risk factors. Are there any family predispositions or risk factors for them that we might be worried about? Am I worried about cancer syndromes in the family? Am I worried about something in their GYN history, in their medical history that may pertain to their fertility? We also do a physical exam, which may or may not include an ultrasound at that first visit. But I'm going to walk you through what some of those initial evaluation steps are. And so just to kind of give you a little bit of a highlight and not to go into too much detail at this webinar, but just to highlight some of the testing that our female patients do are testing to look at their egg number, something called ovarian reserve testing. We do some testing to look at the uterus and tubes anatomically. We do some blood work, which I'll go into in a little more detail. And then we do offer genetic testing carrier screening, which Risa is going to highlight a little bit later as well. And for our male partners, we also do blood work. We do a semen analysis, and then again, genetic testing, carrier screening. Carrier screening is looking, we offer to everybody, not people with specific family histories. They are for things called recessive disorders, and I believe that we're going to talk about that as well in more detail. There are some people that we do want to look at in a little more detail from a genetics perspective, and I will actually refer them to Risa for genetic counseling. There are people that also have some other evaluations that they need, whether medical optimization or other clearances for medical issues to optimize them before getting pregnant, to make sure that we have the best chance of having a successful, healthy pregnancy for both mom and for babies. And so just looking into a little more detail, that egg reserve testing that we do is usually an ultrasound to look at the potential egg number for that month. On this ultrasound, you can see these little dark circles. Those are all small potential eggs called follicles. So we do a follicle count. We do some blood work, two different sets of blood work when you have your period, when the cycle resets. Those are the brain hormonal blood work that we do. We do other blood work at any point in time in the cycle, something called AMH, anti-Müllerian hormone. That's also one indicator of your ovarian reserve. There's other kind of blood work that we do as well. We do some other hormonal testing for things that can affect pregnancy, that can affect fertility, like thyroid hormone, prolactin, a couple of other hormones, depending on the scenario. We do infectious disease screening for both parties. We do some informational blood work that you would want to know before you got pregnant. So we do like a blood count. We look at your measles titers, rubella titers, certain things like that you just want to make sure that you are aware of and fix anything that needs improvement before getting pregnant. And then that genetic testing, that carrier screening that we do offer to all couples trying to get pregnant. Now, in terms of evaluating the uterus and the fallopian tubes, we have a couple different ways that we do that. The test that you see here is called a hysterosalpingogram, where we're able to look at the inside of the uterus here, and there's a dye that we push into the uterus that you see here in white, that you can see on an x-ray. And so it fills up the fallopian tubes and spills out the ends of the tubes. And then we take this x-ray picture showing me that both tubes are actually open and normal shape on this particular picture. There are other methods to take a look at the fallopian tubes as well. And if we wanted a closer look at the uterus, we can do a water sonogram, a saline ultrasound, along with our regular ultrasound to make sure that anatomically the inside of the uterus is normal, that there's not something like a fibroid sticking into the wall of the uterus or kind of poking from the wall inside the uterus. And so we're able to evaluate that in a little more detail. For males, we do a semen analysis that looks at a couple of different parameters. We look at the volume of the sample. We look at how much sperm is in the sample. We look at the movement of the sperm, more specifically looking at the forward movement of the sperm. We're looking at the shape of the sperm, and there are a couple of other things that we can see on a semen analysis itself. And so that's just kind of like a flavor of the evaluation and kind of what we're looking for, why we're looking for those things. But once we do that evaluation, we regroup and talk about what we can do in terms of treatment. So in terms of the theory of that is if we find a specific issue, we're going to fix the identifiable problem if we can. The other theory is to try to grow more than that one natural egg that you're going to grow every month, just to increase the odds of getting pregnant that cycle. We can help coordinate those signals. If you're having difficulty growing that egg in a predictable way, we can help specifically target that if that's our issue. We also try to help by getting egg and sperm closer together. And so that's things like an IUI, an intrauterine insemination, or IVF, and I'll discuss those in a minute. And sometimes what we need to do for treatment is not any of the other things, but we're really kind of focusing on getting extra information about embryos or potential pregnancies before getting pregnant, because we want to have some role with a selection process for medical reasons or other particular reasons. And we're going to talk about that as well. And so how do we help you grow eggs? Well, there's a variety of different medications that can do that. These are not growing new eggs. These are just taking from your individual potential and to try to grow more than one each month. These are either pills that you can take, things like Clomid and Letrozole, you may have heard about, or they can be injectable medications. The injectable medications are typically what we do for things like IVF, although sometimes we do a combination with oral medications as well. The oral medications will tend to help you grow 1, 2, maybe 3 eggs, versus the injectables tend to grow a larger pool of eggs at once. Sometimes can be used for IUI, but typically for IVF. And so just to explain what those two things are, again, IUI and IVF is to help get egg and sperm closer together. So with an IUI, we watch an egg grow. We time when that egg is going to be released and ovulate. And then we get egg and sperm a little bit closer together inside the body by taking a sperm sample and putting it inside the uterus. So it's a little bit closer together to where egg and sperm fertilize inside a tube. And so this is just a little pictorial image of us taking a catheter, passing it into the uterus and depositing sperm sample here inside the uterus. So the fertilization happens inside the body. It's still natural ovulation. The egg is still inside the body. And it's again up to egg and sperm whether they fertilize or not. And then we find out, do we get pregnant or not at the end of that cycle. With in vitro fertilization, the fertilization happens outside the body. So with IVF, we grow a group of eggs, we remove that group of eggs from the body, and then we get those egg and sperm as close together as we can. We actually take sometimes a single sperm and inject it inside each egg. That's something called ICSI. That's as close as we can get them together. And so it helps with fertilization. Doesn't guarantee that they're going to mix properly and fertilize, but it's as close as we can get them together. And then those little embryos will grow. And so those little embryos grow for about 5 days of development until they reach the stage where they're ready to go back inside the uterus. And so on day 5 of development, there's something called a blastocyst, where the embryo is divided into two pieces, an outer portion called the trophectoderm, which is the part that becomes the placenta, and an inner cell mass, which are the cells that eventually will become the baby. And so at the point of an embryo, we could do a couple of things. We could put it back into the uterus to try to get you pregnant. We could biopsy that embryo and do a variety of different genetic testing of that embryo, which we're going to talk about soon. Or we could freeze that embryo with or without the genetic information. And so we sometimes freeze embryos to preserve your fertility. When we biopsy the embryo, we do freeze it because it takes some time to get that result back. So we're preserving as well, the cryopreserving the embryos in that instance as well. And so I wanted to focus just for a second on fertility preservation, one of my other hats. There are some people that go through this treatment process, not because they're actively trying to get pregnant right now, this minute, although they might be, but because they also want to preserve their fertility for the future for a variety of different reasons. And so here at RMA, we are able to do embryo freezing. That's egg and sperm already combined, like I just showed you. And then we freeze them at that embryo stage, where they're ready to be put back into the uterus, that stage. We freeze eggs, oocyte cryopreservation. We freeze sperm for certain men that need to freeze sperm in advance. And we're able to do genetic testing of embryos. And like I mentioned, by doing genetic testing of the embryos, we are inherently freezing them while we wait for that result to come back. And so why, it's not advancing, here we go. Why would we want to freeze embryos or freeze eggs? So some people do it for a variety of different reasons. Some of them are elective, whether there is a social reason why you want to freeze your eggs. You're not ready to be pregnant. You're not ready to build a family. There might be some financial constraints and you want to build a family, but not ready to do it right now, not ready to have the expense of raising a child. There's some psychological reasons why people may defer, pregnancy until they're a little bit older. And at that stage, you can either freeze as eggs or freeze as embryos. If you know who your reproductive partner is going to be, you know what the sperm source is going to be, then we can freeze them as embryos instead of freezing them just as eggs. But there are certain people that have medical reasons why they either medically right now need to freeze or medically have a reason why freezing might be a good option for them. So sometimes that's a medical diagnosis that they have right now. If you have a cancer diagnosis, if you have an autoimmune disease and know you need to be on certain medications that may impact your fertility, or you need GYN surgery, you have severe endometriosis, and you know that you're going to have surgery in your pelvis that may impact your fertility. So these are all reasons why some people come and see me and preserve their fertility in advance of those treatments, those medical treatments. There are some people that come to me knowing that they're at risk for certain fertility issues in the future, whether that's just because they have a family history, a known family history of going into menopause early, or having a lower egg count for a variety of other reasons. There are some genetic predispositions. There's some genetic reasons why women are more prone to lose their eggs earlier, like we kind of alluded to in the beginning of the talk. There are certain genes that actually put you at risk for that we can test for. So there are some people that know about that in advance or have that family history, and we help identify that for them. There are some people that come to me knowing that they need to do or want to do certain types of genetic testing of their embryos, whether they're ready to be pregnant now or ready to be pregnant in 5 years, but they know that they're going to want to do genetic testing of their embryos. And so they'll come to see me to freeze them now when they're younger, when egg quality is a little bit better. We freeze them as embryos and are able to do that genetic testing for them in advance. So they know what they have in storage. They know what their future potential is going to be. And so from that genetic standpoint, I just want to hand it over to Risa, who's going to give us a lot more detail about what's possible and all the amazing things that we can do from a genetic standpoint.
Thank you, Dr. Goldsammler. Hi, my name is Risa. We had the introductions already, so I'm really just going to jump in. I'm going to take you through the second part of the webinar where we really explore the many ways that genetics intersects into fertility care. Dr. Goldsammler mentioned, many of those areas, and I'm going to expound on each of them and share a little bit more as well. Next slide. Thanks. You can, okay, perfect. So this is, referencing back to Dr. Goldsammler's chart on indications for fertility preservation, right? She was mentioning how there are certain genetic conditions where freezing eggs, sperm, or embryos can be especially valuable. So I want to talk about that in a little more detail. And thankfully, Dr. Goldsammler explained very nicely and clearly much of through the evaluation process and a lot of the treatments that we do. So, as you mentioned, some individuals come for fertility preservation because of premature ovarian insufficiency, right, or diminished ovarian reserve. That's where Dr. Goldsammler was mentioning, where individuals can have a lower egg reserve. And sometimes that is due to a genetic condition. One of the things we commonly see, unfortunately, is where an individual is a carrier of something called Fragile X syndrome. An individual who is a carrier does not have the condition. However, she herself is at risk to experience premature ovarian insufficiency. And for them, freezing eggs at a very early stage, right, this means that they may lose eggs at an earlier stage. Freezing eggs at as early as possible is an important step to have their own biological children. Second, conditions that affect ovarian or uterine development, like Dr. Goldsammler said, fertility preservation is definitely meaningful. And lastly, there are some male factor related concerns where there are genetic diseases that can contribute to male infertility. Specifically, cystic fibrosis, you may have heard of. It's a recessive condition that can be tested for. And men with cystic fibrosis have a structural defect that prevents the sperm from exiting the body properly. And IVF, often paired with another, surgical treatment, can help the individual achieve, be able to have biological pregnancy. There are also individuals, like Dr. Goldsammler mentioned, who don't necessarily have fertility concerns, but they want to preserve their fertility and, they want to freeze embryos because they have a family history of a genetic disease that they want to avoid passing on. And in these cases, IVF really allows embryos to be created outside the body so we can extract some of those cells, like that image that we saw earlier. See it in a moment as well. But we can extract some cells from an embryo created outside the body, test them for a genetic disease that a couple might be at risk for, and then only transfer back to healthy embryos. So what are these types of conditions that we're talking about? Next slide, please. There's, a bunch of different categories. We'll start with dominant conditions. Dominant disorders is when an individual is, has a 50% chance of passing on the condition to their child. Just to give a little biological lesson here, maybe take you back to like ninth grade biology. We have 2 copies of every single gene in our body. When someone is a carrier, it means that they have a mutation on one of those copies. One of the copies is not working properly, the other is healthy. In dominant conditions, carriers themselves are affected with the disease, right? Just having one gene not working properly will cause disease. So we do see a significant family history because someone's a carrier and they have a 50% chance to pass that on. We often see in every generation individuals who are affected. Some examples of this, as you see, are certain hereditary cancer syndromes, Marfan syndrome, Huntington's disease, certain cardiomyopathies, polycystic kidney disease you may have heard of. These are all inherited in a dominant fashion. And if any of you suspect that there is a genetic condition in the family, where you're seeing a lot of individuals having similar symptoms, where there's definitely something strange going on, but no one's done testing, it definitely warrants, seeing a medical geneticist, speaking to a genetic counselor, and pursuing testing so that you can make decisions on reproduction if, you know, you can make these appropriate reproductive decisions if relevant. Just a brief tangent on cancer genetics. Um, cancer, cancer is all cancer is genetic. Cancer is, a hot topic out there in the medical world. 5 to 10% of cancers are due to an inherited predisposition, where actually a person is born with a mutation in a cancer cell and a cancer gene. The cancer genes are supposed to protect us against cancer. So unfortunately, if a person is born with a mutation in one of those genes, it's going to be present in all the cells of their body, and it will make them more prone to developing cancer in their lifetime. If someone has a cancer predisposition, it does not mean that they will get cancer. It means that they are at a greater chance of getting cancer. And because these are inherited in a dominant fashion, just being a carrier alone of one mutation puts you at an increased risk for cancer. We often see strong family histories of cancer when there is a mutation floating around, right? So some of the red flags for an inherited predisposition or for, an inherited cause for the cancers in the family is when there's young cancers at young ages, maybe multiple individuals with cancers, same types of cancers, multiple cancers in the same individual. Or if any of you have a family history, a strong family history of cancer that's similar to what I described, it's definitely advisable to take action, right? To seek out cancer counseling, to explore your family history, talk to your relatives. A lot of holidays coming up, right? You'll be seeing a lot of relatives. Not that you necessarily want to talk about that on the holidays, but have those conversations and see if you'd like to, speak to a cancer genetic counselor, do genetic testing, and find out if you are a carrier of a genetic predisposition. Because if you are, then there is that 50% chance to pass it on to the next generation. Not only do you want the information for yourself or your own prevention, but we can act on that. Like Dr. Goldsammler said, we can do IVF, do testing, and really prevent that from occurring in future generations. Back to, conditions. Next, I want to talk about X-linked conditions, which are generally passed from the egg source to males specifically. Females have two X chromosomes. Males have only one X. They actually have an X and a Y. The Y is what makes male a male. Therefore, generally, females are just carriers of X-linked conditions. Being a carrier itself, right, having just that one mutation is usually not enough to cause the disease in a female. In a male, however, because they only have one copy of the gene, if they inherit the mutation from their mother or from the egg source, unfortunately, that individual will be affected with the disease because he doesn't have a second copy of the gene to compensate. Right? So for X-linked conditions, we're typically seeing maternal to son inheritance. Some examples of this, Fragile X syndrome, like I mentioned earlier, Duchenne muscular dystrophy, hemophilia, a bleeding disorder you may have heard of. These are all inherited in an X-linked fashion, and these are all conditions that can be tested for as well. Lastly, and this is really like the largest category we encounter, are autosomal recessive conditions, where this is what Dr. Goldsammler was hitting on earlier, where we want to test individuals before treatments for recessive conditions. Recessive conditions are when both reproductive partners are carriers for the same genetic disease. So as you see here in this image, these are let's say this is a male and female couple, or a sperm donor, female patient, whatever it might be. They are both carriers for the exact same condition, meaning they have one gene that's working, one gene that is not working. Being a carrier for a recessive condition does not put you at risk for disease. Carriers for recessive conditions are generally healthy, right? That's different from what we said earlier for dominant conditions where carriers themselves have the disease. In recessive condition, in order for a child to be affected, they need to have two non-working copies of the gene. And that's what you see in this image, where if two reproductive partners are carriers for the same disease, then there is a 25% chance that a child could be affected. That a pregnancy will inherit both mutations and be affected. Common examples of this are cystic fibrosis, Tay-Sachs, SMA, spinal muscular atrophy, sickle cell anemia. There's definitely ones that cluster in certain populations. We're not going to get too into that right now. But what's very important to recognize is carrier status is generally silent, right? Carriers are healthy. So they don't know that they're carriers. They don't know that these genetic diseases are running in their families. And often, unfortunately, what happens, you know, if they're not being screened by the OB, or if they're not necessarily a fertility patient getting screened, as Dr. Goldsammler mentioned, we screen right away. If someone is not screened and they um, go on to have a child, unfortunately, what happens is that there's a risk that a child is born with a genetic disease. And then we go and test the parents and we find out, oh, those parents were both carriers of that disease. These are rare conditions. It's not like we see them every day, but it's that one family, unfortunately, that gets hit with the condition that we then, again, through familial testing, we find out that, oh, grandpa and the uncle and the cousin and the sister, they're all carriers. They just didn't know because they didn't attempt conception with a carrier as well. So as a result, it is super, super, super important in the evaluation process. And, I know offices do this as well when someone is already pregnant. But when we're trying to create healthy pregnancies, super important to do carrier screening. So on the next slide, carrier screening is a comprehensive test where we look at tons of genetic diseases. Here at RMA, we look at over 400 diseases right now. It's constantly increasing. We want to make sure that reproductive partners are not shared carriers before attempting conception. Before we do our fertility preservation that was laid out previously, we, definitely ensure that there is no genetic risk, or at least as little genetic risk as possible. Next slide. And that's really to prevent, like I mentioned, unexpected findings after a child is born. With this information, why does screening matter so much? If we waited, let's say we did your treatments, waited until you got pregnant to do testing, which is when in a natural pregnancy that might occur, right? The OB does the testing. Then unfortunately, the couple is left with the emotional and mental burden of whether to test the pregnancy, or the fear and anxieties of, oh my gosh, we're shared carriers. There's a risk to the child. What should we do? And then they might do testing. If God forbid a pregnancy is affected, they, have to make very difficult decisions at that point. With IVF, next slide, please. With IVF, as Dr. Goldsammler mentioned, we can do testing on the embryo itself through testing called PGT. Stands for, that's pre-implantation genetic testing. This is really an umbrella term that we use to talk about tests that can be done on embryos before we attempt to transfer, before we attempt conception, before we attempt pregnancy. What we've been focusing on specifically is PGT-M. M stands for monogenic disorder, single gene disorders. And this is the specialized test that could screen for the disorders that we just spoke about. Dominant, X-linked, recessive, whatever it might be, if there is something running in the family or there is an increased risk for a specific disease in the next generation, couples might choose to do IVF willingly, right? There might not be other fertility concerns, but they're doing IVF and doing genetic testing, PGT, for these diseases to, again, reduce that emotional, mental burden, finding out later on, and really to achieve a healthy pregnancy. Now, that is just PGT-M. In order to do PGT-M, we need a specific mutation. So that's why I was stressing earlier that if it is of interest to you to rule out a condition in the family, we want to make sure that you've done that testing in advance, gone to a medical geneticist, a cancer genetic counselor, whoever it might be, to determine what that condition is. If it's a recessive condition running in the family, that's something that we can also detect here with our expanded carrier screening, and we would certainly recommend PGT-M to select against embryos that are affected. You can go to the next slide, and then we'll get back to the PGT-A. this is really the process of genetic testing where Dr. Goldsammler mentioned, is just outlining it visually, right? The IVF process, you do IVF, where you attempt to fertilize the egg outside of the body, again, so that we can biopsy an embryo, send it for testing, and then ultimately transfer a healthy embryo. Next slide, please. This is similar to what Dr. Goldsammler mentioned earlier, right? She mentioned the mature embryo, just I guess a brief review, see if you were listening. A mature embryo, these are the embryos that is ready to be transferred and implanted into a uterus to become a pregnancy. It's around day 5 or day 6 of development, sometimes day 7, that it becomes this mature embryo, right? It splits into these 2 layers that you see here. The outer layer, the trophectoderm, is what we said becomes the placenta. Inner layer is what will become the baby. And so it's at this stage that we biopsy the embryos, take a few cells from that outer layer of the embryo, and it's safe because we're taking from the outer region, the placental region. Only a few cells. We're not taking cells from the fetal component, so we don't have to worry about any missing limbs, any complications. It's strictly that outer layer, few cells, and it is again a safe procedure that can significantly reduce risk down the line for a genetic problem. Next slide, please. So I mentioned we had on an earlier slide the different categories of PGT. PGTM was the one we focused on, but PGTA is actually the most common test. PGTA is standardly done, honestly, for most IVF patients at this point, where, even if there was no genetic indication, you didn't have any genetic concern in your family, if you're doing IVF for other fertility concerns, there's a good chance they would be testing your embryos with PGTA. It's done on the same biopsy. So we're not taking any extra cells. But that same biopsy we would send out for testing, and the lab would do PGTA analysis or pre-implantation genetic testing for aneuploidy, for chromosome abnormalities. With PGTA, it's really like a zoom out onto like the chromosomes as a whole. We're looking at the chromosomes, chromosome number. We want to see the amount of genetic material present, make sure there's no extra or missing chromosomes. Something you see here on the right here, the left is showing 2 copies of every chromosome. That's what we want. On the right is an example of an extra chromosome, a trisomy 21, which would result in Down syndrome. And that's why we are looking not only at 21, we look at all the chromosomes, but we want to look for any imbalances in the embryos that unfortunately would contribute to failed implantation, miscarriage, or other abnormalities in a future child. This slide just summarizes what I just mentioned, but I do want to add that I said PGTA is really for most IVF cycles, but who is it really most beneficial for? Definitely individuals with advanced maternal age, or Dr. Goldsammler mentioned, as we age, she had a little chart at the beginning, as we age, our eggs age as well. And the risk for chromosome abnormalities increases. Someone at 37, 50% chance that the embryo will be abnormal. So it's just, natural because we're looking at such an early stage of development, right? Before the embryo even attempted to become a pregnancy. For many people, there could be individuals who conceive and don't know that they've conceived in a natural pregnancy because it never results in a pregnancy. Multiple reasons. One of those reasons is because the conception could have been genetically abnormal, right? So we are looking at the embryos very early on before conception is attempted, before pregnancy is attempted, and that's why the chance of abnormality is so high in an embryo. And that's really why we want to look at these embryos in advance before transfer to ensure that we are transferring a chromosomally healthy embryo to really improve the transfer rates and shorten the time to get to a healthy pregnancy. Other reasons why an individual might choose to do PGT is because they actually have their own structural rearrangement. This is an example of what you see here of a translocation where pieces of 2 different chromosomes actually swap places. And there are many healthy living individuals walking around with translocations. They wouldn't know, it's not standardly done on testing at their doctor. It is testing that we might do if an individual has recurrent pregnancy loss, or family history. If I see a family history of diseases in the of broad spectrum conditions where individuals are affected, maybe with like autism and congenital defects, intellectual disability. If there's a bunch of you know, broad things going on, and an individual is having recurrent pregnancy loss, then there's a concern that maybe there is a translocation. The individual carrier, his or herself, is generally healthy for the most part. Um, so they might not know because they have all the genetic material they need, but the problem is really in reproduction and sperm or egg development. It can cause abnormalities in the embryos. So PGT is very important for these individuals. And we would add on a PGTSR similar to PGTA, it just looks a little more closely at the problematic chromosomes. Um, Now, once we receive the results, right, we send it out for testing, we receive results, we know that hopefully, we get good embryo results, and then you can proceed with the transfer, knowing that, hopefully everything is healthy. Um, when all the testing is complete, whether it be the carrier screening, whether it be outside genetic testing to determine if there's a cancer predisposition, whatever it might be, whatever genetic testing we're talking about, in a genetic counseling session, Dr. Goldsammler might, refer to myself or a genetic counselor to discuss what your risks look like based on your results. Maybe there's additional testing that's necessary. We can talk about screening options. What options, what can we do to further assess what the risk looks like? We guide you through complex medical information, talk about treatment options based on your results. And definitely there's, the IVF process, there certainly is a lot of, there's a lot of emotional support necessary. Can be an overwhelming process. Genetic results can certainly be complex as well. And that's where all of us at RMA, which you'll see on the next slide, it definitely outlines this. Everyone at RMA is really there to work collaboratively, right? Our physicians, the nurses, myself as the genetic counselor, we have a social worker as well, the coordinators, the embryology. Everyone is here working together to make sure that you're not overwhelmed, that you feel supported, informed, and really never alone throughout the journey from start to finish. Um, and yeah, that's really. We are so happy that you took the time to talk to us, to listen to us today. If you have any questions about genetic testing, treatment plans, anything for Dr. Goldsammler, definitely don't hesitate to reach out. The number is on the screen. And I know we're going to open the floor for some questions as well.
So I have the Q&A open. Thank you everybody for listening. If you do have any questions, please put it into the Q&A on the bottom. We'll try to answer as much as we can. So there is a question here that says, and I'm going to just repeat the questions. Are all of the diseases you mentioned able to be tested for if someone gets pregnant naturally without IVF or IUI? That's one. And then can both parents get familial testing done before trying to get pregnant without intervention? What does that look like, blood work or something else?
Yeah, so I'll take that. Those are great questions. And yes, testing is certainly available outside of the, IVF clinic space. So if we're talking about carrier screening, right, whether a couple are shared carriers or if a female is a carrier of an X-linked disease, um, often what happens is that people don't go for screening before pregnancy and they come to their OB, they're pregnant, and the OB does the testing at that point. So OBs do the testing, it can be done through saliva, blood, but we of course encourage testing in advance, and you can do this. Firstly, if you have a gynecologist, you can do it through the gynecologist because usually they do it on their OB patients either way if they are an OBGYN. Alternatively, there are genetic clinics. There are a lot of genetic counselors that work in the various hospitals, or work privately, work through telehealth, and you can definitely schedule a call with them. There's I think it's called nsjc.org. So where you could find a local genetic counselor. You write what the indication is that you're looking to look for. It could be carrier screening, preconception screening. You can certainly do that, and find out if there are risks or if you need to pursue that route at all. Um, the
The
se-
one thing I want to just interject, if it's okay, I think the major difference between doing this kind of testing during pregnancy versus before pregnancy is the opportunity to intervene ahead of
yes.
time. And so if you know that you're both carriers, both at risk of passing a certain disease to a baby, or if you know that you have a cancer gene and you have a 50% chance of passing that cancer gene to the next generation, we can eliminate that risk for you by doing IVF with genetic testing and actually stop that transmission to the next generation. When you find out that information when you're pregnant, like Risa mentioned, you have some tough choices to kind of make at that point. There's certain testing that we can do of pregnancies. There's certain testing that we can do of children or babies, and there is certain limitations to genetic testing of children. I know that there's a lot of ethical literature and concerns about doing certain types of genetic testing on children. Sometimes you have to wait until that child is of adulthood before you're able to do certain kinds of testing for them. And so that's just something else to kind of keep in mind. Obviously, if there's a medical concern that you need to do testing on a child for, that's a separate indication. But some of this carrier screening, for example, you may not be able to do of a child, but you may be able to find out information during pregnancy itself. Hopefully that answered the question. Let's see. Um, did anyone have any other questions?
We can, I, we can give another minute. Dr. Goldsammler and Risa, thank you so much for your presentation. That was really insightful and full of information. So I do want to reiterate, if people are kind of still digesting the conversation this evening, yeah. This was recorded, and so we will be sharing the video, and you'll have the slides on that video as well to review on your own time. I know, like Dr. Goldsammler just said, it is a lot, and oftentimes the language, if you're not used to it and using it in your everyday life, can feel like a whole other language. And so I think having the time on your own to take a look at some things, visit our website, and then if you still would like to speak with someone, our team is always available for an initial consultation or to answer any questions at the number on this slide below. And so I would encourage you to reach out. Honestly, I think the best thing is to come in for a conversation with Dr. Goldsammler and or Risa, and any of our other physicians who are all wonderful. We have 6 offices throughout Long Island, with physicians seeing patients at all of them. And so we really try to make this process as convenient and accessible for you while you're going through it. We really don't want to disrupt your everyday life. And so again, I think coming in to speak with someone or speaking someone over a telehealth conversation, but just having that one-on-one conversation will probably be the most helpful, especially if there is a genetic factor or consideration in your fertility journey. So if there are no more questions, and if Dr. Goldsammler and Risa, if you feel fully concluded on everything you wanted to say, then I think we can end the webinar here. I want to thank our panelists. And again, I want to thank everyone for coming. Appreciate your time this evening, and look for an email tomorrow that will have the recording of this. So thank you so much, everyone.